those who don't know me, I'm Susie Lawless, a GP in Dunedin, and I have had something of an interest in dementia over the last few years for all sorts of reasons. But the reason I'm actually facilitating this evening tonight is partly because I have met such interesting people with interesting messages about dementia and how we're going to achieve some more positive outcomes. And Helen, you're sitting in the wrong seat, so I'm going to get you to come and sit in the seat up here because you're part of our panel tonight. So I'll introduce you to our panel members as we go. So we have someone representing the community as a person who supports a partner with dementia. We have a psychologist, Needs Assessor, and this is a little bit like 7 days, you have to guess which is which. We have someone from the Alzheimer's Society, and we have a barrister with an interest in assessing mental capacity, and I think that might be all we have. So that's good. So first I'd like to introduce you to Susan Miller. And Susan I met a couple of years ago when she moved back to Dunedin to support her husband who is living with dementia. And I'd have to say she is a social lobbyist, shall we say, as well as someone who has a PhD on the subject of cognitive stimulation. But she's going to speak to us, and each of these speakers just gets a short amount of time. I'm the timekeeper. So you go, Susan. I will hand you this.
Oh, thank you, Susie. Oh, well, no. To work the computer, it's always interesting, isn't it?
Would you like me to do your slides?
If you can get them, just put them on.
Susie, go to the bottom, drag up, there you go. Slide show at the top there.
Great, thank you. All right. My name's Susan too, as you've just heard, and I support my husband David, who's had dementia he was diagnosed 10 years ago. So I've been caring for him for 10 years. And probably before that, when we look back at some of the peculiar things he was doing, we probably think he had it for about 10 years previous to being diagnosed. The purpose of my talk is to really talk to you about the Alzheimer's Society and how useful that has been to us, both in Australia and in Otago, and in the Alzheimer's Society of New Zealand also has been very helpful, and how they've supported us. So I'm going to start off with the diagnosis David got. In 2007, he said to me, there's something wrong with my brain. I didn't get it. I didn't think there was anything wrong with his brain. I'd never heard of dementia, really. I'd heard of senility, and in the family we'd had people that went senile, but I didn't know anything about it whatsoever. So at the end of 2007, he had an MRI, and at first it looked as though it was okay. He was called back in February 2008 because specialists were looking at it, and they found little yellow blobs over it, which was actually the results of vascular dementia. He was given some statins, and he came home and told me he had these statins and he had clogged up capillaries in his brain, and the statins would stop the cholesterol doing that, and I thought that was it. I thought that was the cure. So I wasn't really involved in the diagnosis at all until September of 2008. I was at a doctor of 25 years, and as I wandered out of the room, I said to her, what's the prognosis for David? And she told me, and I was stunned. I couldn't believe it. I just burst into tears, and it was the first I'd heard of it. She said, didn't the memory clinic call you in? I said, no, nobody mentioned it to me at all. So that was the diagnosis. I went to work the next day and resigned because I was horrified that my husband was at home dealing with all this on his own because he worked from home. And so that was the diagnosis. And I suppose it's based on a medical model, and I'm certainly not criticising the medical model. It's marvellous. And I was reading the other day that the cure for tonsillitis used to be ground up dead man's dung, pushed into your tonsils with a straw or blown in. So I think, we've made amazing strides since then, hopefully. So we've certainly got very grateful for the medical model and its reductionists, that they were just looking at David's brain, and that's how science works, and that's how we get a lot of marvellous results. There's nothing wrong with that either. And but we can have the next slide, thanks, Susie. I just want to mention this about the communication. What I was suffering from was an incredible lack of it. And one of my favourite authors, Strauss and... I've had a mental blank. Anyway, they wrote a book in 1965 about communication with patients with diseases and how to be honest about it and how to inform them of it. They did a review of it in 2015 and found 50 years later what they were saying was still very relevant. And I know the communication thing's really difficult. I was a school teacher and spent the latter part of my career going around trying to get science teachers to communicate with their students, and it was really, really difficult. It sounds easy, but it's not, and probably depends on the area that the person's working in as well. But I just put that there because I thought you might find it interesting and to have a look at. You can have it just on the net. So here we had our diagnosis, and we both knew about it in September 2008. So immediately it impacts in many more ways than the medical model, does impact. We had the statins and various other tablets. David's health was beautifully controlled, but then we had all these other things that really impacted on our everyday life non-stop, like the family. Could they cope with it? Did they want to think that their dad had this awful disease? Well, they sort of do and they sort of don't, and it's difficult. Friendships was an interesting one. In the end, I could tell by the people's eyes when they were at our place whether we were going to see them again or not. Sometimes people just don't know how to react, or they feel frightened, or I just don't know what it is, but everyone will tell you that usually quite a few friends drop away. That's horrible. Then there was work, and we kept David working until 2012. He lectures in art history and the history of music, and he did his final lecture in 2012. It was very exciting, I can assure you. But in the end, he just couldn't cope with putting the storylines together. But it was great, that he kept going that long. Then he got more ill, there were more symptoms, and it has got to the stage now that when he wakes up in the morning, he says, "Where am I? Who am I? And what could I do?" What he really would like is still to be a functioning member of society. And I think people with dementia start to feel that they're being pushed out and pushed out and pushed out. And I don't think the medical model of rest homes helps at all with that. And getting around was difficult. We'd go out to things. We lived in Sydney, it's a huge city, everywhere was a trek. He had some interesting habits, like he'd say, I want to do, excuse my language, but this is what he said, I want to do a pee, and we'd be out with our family, and he'd be behind a tree or not behind a tree. And they found that really, really difficult. It is quite difficult. I was always kind of rushing him and pushing him if I saw kids, because it was very hard to stop him, because like a lot of people with dementia, he was disinhibited. So he said and did things that we normally wouldn't. Sometimes that was hair-raising and sometimes it was utterly hilarious. But he is quite a funny person to live with. So he was living at home and able to do less and less and less. It means that I was doing more and more and more. So I don't mind. I like looking after him, but you only have X amount of energy, and that's difficult too. Then there's the constant grief and heartbreak. You're just sitting there watching someone die in front of you, and it's absolutely horrible. And we have great days and we have revolting days, and that constant grief is just there. Thanks, Susie. So the Alzheimer's Society. Our doctor never told us about it. Not a thing. The doctor said to us, said to me the day that she told me about the diagnosis, she said, "Look, don't worry. The first 2 years are the worst, but once he's totally gaga, it'll be easy because he won't know anything. Be fine for you." Well, 10 years later, and he's still not totally gaga. The idea that when a person gets a diagnosis of dementia, that their intellect just disappears down the drain is just so wrong. David is still incredibly insightful about things. I read to him. I read books by people like John Julian Norwich. He's a historian. David can understand all that sort of thing. He can't read it so well now, but he certainly understands it. And there's plenty of intellect there. The other thing that seems to, often people think goes is their feelings and their emotions, but research shows us that the amygdala is about one of the last things to be affected, and they will always be able to feel that they're loved. And that's really important. So after about 2 years, I can't even remember how I found out about the Alzheimer's Society in New South Wales. Somehow I did. And I went to their counsellor and had a chat, and then I suddenly was introduced to social workers. I had so many because in Australia they divested different areas of the health care to the Presbyterians, the Catholics, the this and the that. So if you had a service from each one, you had 4 social workers. And they were great. We had been told by the doctor, by the GP, and also by these I always forget the name of these ones, these psychiatrists for old people, Thank you, Susie. She said to me, "Look, just sell your house, get out of it. Just don't worry about fixing up the gutters or anything, just sell it, get into a retirement village." And the GP said the same, and we nobly went round and looked at retirement villages, and I was 61, I wasn't and they said to us, people really are not going into retirement villages as early as, it's often not until their 80s, so it wasn't my scene at all, and I found that difficult. But the social worker came and she said, "What are you moving out of your house for? What do you want to leave your home for?" So we didn't, we stopped all that. And the Alzheimer's Society provided us with a lot of support, a lot of research and education. We did living with memory loss. Every social worker had a living with memory loss program, and because I liked them all, I went to all of them to support them. But they were very, very, very helpful. We had things on, like there are carers groups and support groups. In Sydney we had a thing called the ad hoc dinner. They have a sort of one here too, don't you, like that. Other social events where we made new friends. So we lost friends, but we made new friends, which was nice. And we got a lot of local information, and when we came to Dunedin, we were strangers, and the first place I went to was the Alzheimer's Society because they gave us all the local information, how we had to go to a nurse assessor. We heard about Helen's course and other things that we could go to, and again we met people and got to know them.
That's 10 minutes.
That's 10 minutes, yes. I am. So basically it gives you a connection in the community and does a lot of work on reducing the stigma attached to dementia, which always pops up. And it also emphasises that whether you've got dementia or not, you're still a person. Thank you.
So we're going to keep all our speakers here as a panel, and there will be an opportunity to ask questions of any of them later. One of the things I was very impressed with, Susan, when you and David turned up in my surgery was that one of the reasons you came back to Dunedin that you told me was that David grew up here, and it was much easier for him to adapt to an environment that was familiar from his early memories, and I thought that was a wonderful thing that you did to come here. So when we diagnose someone with dementia, and this is going to happen increasingly, we are managing them far more in primary care, and part of the reason for this conversation is about how do we help them most. And when I've got my new diagnosis that I'm pretty sure I'm making, I've got a few referrals to make. I'm going to refer them perhaps to the memory clinic, and we'll talk a bit more about that. But the question I want Julie Butler to answer for us, Julie Butler is the manager of Alzheimer's Otago. I want to know, why should we bother to pick up our cursor and do the ERMs for the Alzheimer's Society? What will that give our patient that they won't get anywhere else? So come and tell us about that, Julie.
Put me on the spot here.
Yeah. Why should we refer to you?
Why shouldn't you? I don't think I'll need that. I've got a loud enough voice.
No, it actually records for the podcast, so I do need you to hold it.
Oh, okay.
Thank you.
Yay. Right. Well, that just, on my wee list of what I was going to talk about, shot in the foot now. So why should you refer to us? Well, yeah, again, why shouldn't you? We look after folk from a different angle from the angle that you look after folk, I suppose. We have field workers or community support officers. We have 2 based in Dunedin who support families directly from sort of Palmerston right down to Tapanui. So they meet with people one-on-one, either in the office, in their home, the coffee shop, wherever they want to. They can spend the time. I mean, our first home visit can, be 1 or 2 hours sort of thing. Now, I'm assuming from your practices that they're pretty the same as the one that I go to, and I get 10 or 15 minutes if I can squeeze it out from my GP. So you don't have the time, I guess, that we do. We emphasise very much that we're not medical professionals, so we don't look after the medical side of things. Having said that, a lot of our people talk to us about an awful lot of stuff, so we can encourage them to go to the doctor about X, Y and Z, where sometimes they wouldn't, or they might have had adult children trying to get them to go, and they don't listen to their kids, because let's face it, we listened to them when we were growing up, but they'll listen to us. Not always, but often they will listen to us. We have our support groups, which are for carers, and they can be a spouse like Susan, or we have adult children coming along, we have friends, we have neighbours. That was how our organisation was first established in 1982, and it's a similar story right around the world, because the diagnosis was happening so much later. The supports were all going directly, if you like, into the family as opposed to for the person with dementia. We provide them with a lot of relevant information fed to the folk as and when they need it. So, the internet's this fabulous tool, but I've had a number of families come to us saying, we went on the internet, oh my God, because not everything is going to happen to everybody who has dementia the same way. So I've actually, I don't have enough hands. We've got these really great booklets here. I've left a set out there if you want to have a look, and I'm happy I can provide one for each practice, for each practice if you want them, if they're of any value to you, to have a look at some of the things that we do offer to families, just to, reassure yourselves that our materials are professional and of a good service. But so we have lots of written information about lots of different type of things, but also people can talk to us quite freely. I've had a number of people over the years tell me that one of the most beneficial things they've had from us is a non-judgmental ear. I mean, we've heard it all before. There's nothing anybody can tell us now, most of us have been in the job for quite a few years, that we haven't already heard, but they're things that they couldn't necessarily say to other family or other friends, except perhaps from the friends that they meet through the carers groups. Now, up until quite recently, all we really had was services directly for the carer and the family. That's not to say that the person with dementia was ignored or not supported. When we did the home visits, obviously we talked to the person with dementia as well, and people with dementia still came into our office and asked questions and that sort of thing. But quite recently, it was last year, wasn't it, Sue? The coffee...
Yes, last June. Yeah.
Last June, yeah. Sue, I guess, kind of goes a boot up the backside, and we started. She started really. We do a coffee group, and why I'm very passionate about this group actually, and there's a wee flyer that Sue's put together out there for you. Is very wee, is because it's for the person with dementia and their carer, because I had been thinking about it for a while. And I thought, we're out there in the community all the time, me in particular, talking about how we shouldn't segregate people with dementia, how, we rock on up to people's houses with our cars that have Alzheimer's logo on it, and, we should be out there talking quite freely about it because there's nothing to be ashamed of. And Alzheimer's New Zealand are very focused on dementia-friendly communities, and Dementia Friends is a new initiative that they're going to be looking at probably next year. So the coffee morning, I thought, why should we have something just for people with dementia, and then we've got the carers groups just for the carers? Why don't we do something for people together? And that's because that's also something I've heard a lot. Now that people are getting diagnosed a bit earlier, they want to keep doing things with their partner or with their adult child. And let's face it, we all meet friends for coffee, so why shouldn't people with dementia do something like that as well? And I think it'd be fair to say that it's been a huge success, hasn't it, Sue?
Yeah, so far.
So far.
Fragile.
Yeah.
People come and go rather quickly.
They do. But they also go on outings. It's not just about meeting for a coffee. They go on outings, and we've had a couple of people say, hey, we rock on up to Toy 2 or the art gallery, and they get a speaker and all that sort of thing. And nobody knows which one of us has dementia, so they're treated, I guess, the same, and that's really, it's great. we talk a little bit about stigma, and that is changing. You know, I've been with the society now for 17 years next month, and certainly when I first started, you know, all these groups have to find speakers, you know, so they sort of go down the list of charities and, you know, you get picked for a month or whatever and off you go. And I'd go to give a talk and they'd be, oh, look, I'm really sorry, but, you know, nothing personal, but nobody wants to hear about dementia. Now you go and talk to these groups and, you know, everyone's there. It's sort of like, gosh, we haven't had this many people here for months. And it's certainly not because they have the great desire to look at me or listen to me, but it's because it's impacting so many more people. And so we're out there in the community, and what's really exciting is that we're getting groups coming and saying, well, look, you know, at our Rotary Club, we've noticed a couple of people that have got issues with their memories, you know. So we go out there and we can talk to them about that, about how they can support that person. Because what I say to people is, you know, if you've got somebody coming along to your group who's had a heart attack or a stroke or something like that, you know, you make adjustments to allow them or enable them to continue to come, whether somebody picks them up or they've got a walking frame so they get the seat at the end of the table or whatever, you make an adjustment, and I don't really see why dementia should be any different. Certainly not to start with anyway. I mean, a diagnosis of dementia doesn't automatically negate all the achievements and the accomplishments and the value of that person. So it's really important for us to help people in the community and the families and the people with dementia themselves understand how they can still live well with dementia. Now another, well, I suppose I don't know if I've actually answered your question or not, Susie, but one of the things I'd say, and I know it's a drag, you guys have got so much to think about and so much to remember. I mean, there's some referral forms out there. If you want them, I can give you a supply or whatever. I don't care how I get a referral. You can fax something through. You can go through the dementia pathway. You can, you know, write a letter and put it in the post, whatever. It doesn't matter. Send an email. The important thing is that the earlier people get to know about us, the better. It doesn't even matter if they don't have a diagnosis. I mean, if I had $1 for every time someone's told me in the last 17 years, oh, I wish I'd known about you sooner, I wouldn't have to spend half my life fundraising and filling out grant applications. You know, now we've had a number of people come to us, make that initial contact, whether they've seen a brochure or been referred or seen something in the paper or whatever, and they might just get our newsletter for a couple of years. We send one out every 2 months, you know, and that's all they get because everything's fine. They don't actually need anything more. But then when things aren't so fine, which, you know, invariably happens, they know where to go. And they've already made that contact, so it's a lot easier for them. I mean, if they wait until things hit the fan to try and contact us, then often, I don't want to say it's too late, but it's just that much harder. And, you know, if they're in contact early enough and we're working with them, you know, we can prevent some crises from arising or help put other things in place. And we don't... Sorry? Oh, that's my time. There you go. Yeah.
This is my most important job.
That is your most important.
Yeah. So thanks, Julie. Sorry. One of the referrals I will do when I see someone with a new diagnosis of dementia is I do refer to the needs assessors. Okay, so I go, right, there are some really significant needs that are arising in this little dyad or family or this individual living on their own. They may be physical, they may be psychological. And what I want to know from Helen Cannon, who is representing the needs assessors for the Southern DHB tonight, is when I send that ERMS referral for the kind of, you know, general assessment and I pick the needs assessors off there and I send it off to you, what happens next and how do I write a really good referral to you that will get what I need for my patient? So, come and tell us about that.
Okay. Right. Let's see. Yeah, I was asking my colleagues because we're quite a big team and 3 of us, myself included, do assessments in the hospital and the rest of the team will go out and see people in their own homes. So the girls were saying today that as much information as possible on the referral and perhaps why the referral is being sent is really helpful because we have to do an inter-eye assessment. So it's mandated by the Ministry of Health. So we're no longer writing out these handwritten awful things we used to do. That all changed about 2010 or not long after. So the inter-eye assessment, it's quite comprehensive, and when the girls go out to see someone in their home, it can take anywhere from an hour to 2 hours, particularly if you've got someone that is talking and getting off the point. So it's a comprehensive assessment. We're looking at all sorts of needs. So we want to know, is there a carer, is there a spouse? Because that's a big flag for us, because carer fatigue, as you will well know, Susan, is a huge one. So we're looking at the person, I suppose, holistically. We're not looking just at that person. We're looking at who's around them, who isn't around them. And so you send your referral off and it comes through the single point of entry office, and the clinical coordinators then direct them off to wherever they're meant to go. So our community needs assessors are in geographical teams, so that's probably given you a little bit more of continuity, that you perhaps worked with certain needs assessors in particular areas. They will get the referral, and based on the information you provide them, they will prioritise them. And I believe there are Ministry of Health guidelines over, a really urgent referral has to be seen within so many days, and going down to something that's less urgent. So we're not an urgent service, though the girls often in the office 4 o'clock on a Friday afternoon would beg to differ when they're getting all these referrals begging for, we need respite care, and we're thinking, well, it's Friday, why has that suddenly become a need now? Could this not have been anticipated earlier? Also, we're working within limited resources. It's all about the money, isn't it? Unfortunately, and putting in support for people with dementia is sometimes quite difficult, because we don't have the exact right match of supports. We can put in carer support to acknowledge a carer, and they can use that however they like to basically give the carer a break, be that getting someone to come and sit with them while the carer goes out, or maybe using it to part fund some time in a rest home if that's appropriate. We can send them off to daycare if they're still appropriate for a daycare program, but given that they're not a secure facility and they're dealing with people with multiple needs and diagnoses and medical conditions, but if a person starts perhaps to wander, or the behaviour starts to become a little bit out there, it no longer is appropriate. So I'm really envious of Napier and Hastings. I was up at the This Is Not Your Home conference and talked to a couple of needs assessors. They've actually got a dedicated dementia daycare. We've been crying out for one of them for years. So that would help, because it's a secure place. You would hopefully have people who understand dementia, and it's stimulating perhaps for the person, and it gives the carer a break in a safe environment. When a person lives on their own, we'd put in all the usual supports, perhaps morning, evening, whatever, medication checks, whatever. Perhaps try and get family to disable the range and get Meals on Wheels and things like that. Respite care, we sort of had to clamp down on that a bit. It's really now for emergency crisis situations. So it's not dished out like it used to be when I first started this job. What else? Rest time, when it comes to residential care, that's probably that is the last resort. I mean, it's a brief from the Ministry of Health as well, and that's all very well, the Ministry of Health saying keep people at home, but if we don't have the appropriate supports, we're kind of in a hard place there, because what do you do? For some people, residential care is exactly the right thing that needs to happen, but it's not for everyone. So we've got people at home that would otherwise be in a dementia hospital, D6 level care, and maybe they've been lucky, they've got a good family support as well as whatever we can throw in to help, and that works well. But it's not like that for everyone, so we trying to put in whatever we can, trying to be creative with the Ministry of Health's funding and resources, perhaps in ways that they never dreamed of that we would use them. But really just trying to help to, recognising that here's a family, they're people of value, they might have a dementia maybe, but it doesn't make them lesser of a person, and you still want a good quality of life for them and their family. So that's pretty much what we do. Is that my time up?
Thank you. No, you've got a little bit more.
else?
You've got more to tell us.
One of the girls was saying that the girls in the community don't have the resources that I do in the hospital. Like, we're drawing on a lot of knowledge, so assessments from physios and OTs, and the girls go out to someone's home, so they relying on the information that you send with the referral, but also from the person, but that can be a bit dodged. So hopefully there's a family member there, because mum or dad might be saying, oh yes, I'm doing all these things, and the daughter's saying, no, she's not. So to get a little bit of reality there. The girls were saying that sometimes if you know, people that are known to you and you refer them to us, if their competency is in doubt, you know, who's going to activate the enduring power of attorney? And I guess Alison will talk more on that. Yeah, we do our best, but yeah, it's pretty much.
Thank you. And it's a very good pathway to get people into the care and the support that they need. And it is very responsive, I found, you know, that when we refer to you, we get something happening, which is really helpful. I always think, you know, whenever I've been to family conferences, there's this moment where somebody says, this person has a supportive daughter living in Dunedin, and everybody goes, good. Or even a daughter-in-law. I don't know why sons don't have the same effect on family conferences, but daughters do. Recently, I have been sending referrals off on my ERMS form to what I think of as the memory clinic or the psychogeriatricians, and more than once I've had a response back going, yep, you've diagnosed correctly, this person clearly has dementia. Follow the health pathway and tell us whether you want a CT scan, and we'll send them to the Coping With Forgetfulness group. And I have known nothing at all about the Coping With Forgetfulness group, except that Helen Paton's name is all over it. So now that I seem to be the person managing this dementia without necessarily backup from my colleagues in secondary care, I'm really interested to know what's happening with these patients who are going off. So Helen, can I get you to tell us about coping with forgetfulness and what is actually happening in the hospital when we send that referral to you?
Gosh, that's a good question.
Oh, what's happening in the hospital? You've only got 10 minutes.
I don't know if I'm going to be able to answer that. Okay, so I'm a clinical psychologist working in older people's health. I've been there for 17 years, and there's been quite dramatic changes. And in the next 30 years, we're expecting an 83% increase of people aged over 65 in Dunedin. So, therefore, things are changing. I have to say that in the 17 years that I've been here, there's been no increase in what I do. So therefore, there is a lot of change, and there will continue to be change. So also, please excuse me, I'm on annual leave and I've just driven back from Central today, so I'm still perhaps trying to find my feet. I'm going to cover quite a few different things in the 10 minutes. First of all, I will talk about Memory Clinic. It is currently being restructured. It's gone through a few different versions. Currently, I coordinate it, but the referrals, if you send them to Mental Health Services for Older People, will go through their referral process. If you send them to Older People's Health, they'll go through their referral process. I'm not a part of this. So I then get given the referrals they think should go through a memory clinic. So I'm kind of acting in faith that things are going in the right sort of direction. There have been letters which have perhaps bounced people back, and again, they're not letters that I'm writing or making the decisions about, and I'm not sure whether this is a process that will continue quite like it is, so there may be some changes around that. So certainly there is the cognitive impairment pathway, and I hope all of you know something about it. And I'd certainly encourage you to really look at this thoroughly. It is something that I have contributed to in the southern region, and we're looking at making it a South Island-wide cognitive impairment pathway. It's quite deliberately called cognitive impairment. It's not dementia. I will talk about that more. No, I will talk about it now, actually. So the whole purpose of Memory Clinic is that we actually have geriatricians, psychiatrists, myself, and I'm hoping some others in the future involved, so that we actually get cross-discipline
assessment and just thinking about what needs to be done. We want to get timely diagnoses. There have also been changes, you may be aware, in the DSM-5. It's been changed to being called a neurocognitive disorder. I, for one, am fully in support of this. I don't like the word dementia. To me, dementia is somebody that is lying in a bed, unable to feed themselves, unable to walk, and is in the terminal stages of something like Alzheimer's disease. We're talking about a chronic illness that goes for years. So how do we actually get the diagnosis done in a timely manner, in a way that isn't going to be giving the sort of stigma that people have been experiencing? So whether it's minor neurocognitive disorder in the way that people are still functioning relatively independently, they're driving, they're part of the community, as compared with major neurocognitive disorder, where they are starting to have trouble doing activities of daily living. They're just needing that extra support around things. There may be some questions around formal supports. So this is a really important thing. I now want to just talk about cognitive screening, huge area. I'm currently undertaking a project in the hospital for inpatients. We're looking at how well these are being done when a fourth year medical student is being handed a mocker form and being told, go and do this. And they're going, oh, I've never seen this before. So we're looking at a process for doing this. I'm actually thinking that this is something that I'd like to share with the community as well, and it's something that I'd hope to perhaps publish in the future. So watch this space. Now, when people are perhaps younger, or there's more complexities, there could be questions of depression, or there's some unusual part of their presentation, perhaps a less common dementia, they'll get referred to me for neuropsychological assessment. So this is what I regard as my specialty, and it's certainly is not something that most psychologists have a lot of experience in. So it's something that does take time, and they go through the process and they come out with recommendations, perhaps a diagnosis, but it might be, let's see them again in 18 months and see how it's progressed. I'm working, I love Helen, I'm working within a limited resource. I have a long waiting list, but I'm trying to look at ways to actually chew through this. So I appreciate your patience around this. Now, the last bit, the Coping With Forgetfulness group. How long have I been talking? Okay, the Coping With Forgetfulness group, this is my baby. Okay, this started because I was doing the neuropsychological assessments and thinking, okay, I've given them a few sort of glib suggestions, such as, you know, let's use a whiteboard and use a diary, and off they go, and they probably don't, unless they always have. So I started the group in 2008. That was its first inception. With the restructuring that always happens in the hospital, we couldn't provide it for about a year, and it restarted in 2010. It's run in conjunction with the Alzheimer's Society, but it's really aimed at people that have not received a diagnosis such as Alzheimer's disease, or they may be in the mild stages. It also has to be for people that has some sort of support person, whether they're living with them or they're living near them, that has regular contact. So I've got pamphlets here for patients, designed for them. We run 4 of these groups a year. They go for 9 weeks. They are a really practical, down-to-earth group. Would you agree?
Yes.
Yep. Yeah. Okay, so Susan's had experience of this. And I think you might have been a bit dubious at the beginning, perhaps, just wondering, is this something that's going to help? And I hope that it lived up to your expectations.
What was that?
Sorry.
No. That's actually a very common response. So the people that are forgetful will say, I don't know if I want to come, because they're thinking in their head it's going to be people that are, going nuts or something like this with the stigma. And then the other people who are supporting them will think, oh, what if we see people that are far worse? Okay, so this is a real balancing act. This is why I've become more and more stringent about who actually goes through the group. If I deem them as being too impaired, I will decline them. Sometimes I'll think, okay, say if they're out of area or there's some other complexity, I'll do a one-on-one session of 1.5 hours condensed, taking out all the group stuff. They're given written material to take away. The whole concept it's based around is cognitive rehab. So that's all about, in the context of a brain injury, that we're teaching people how to bypass, how to manage, how to accept, how to cope with these changes that are happening to them. So it's working on a whole lot of different levels. It's a group in which we do goal setting, problem solving. I've got pamphlets that I've put together for making referrals, seeing as we're perhaps getting less of the people coming through if you're diagnosing using the cognitive impairment pathways. But really I have to stress we need people to be early, mild, because if we're wanting people to make changes, that's the time to be particularly doing it. What else do I need to say? We have refresher sessions run twice a year, and we have a combined group, and we ran one 2 weeks ago, was it? And we had 34 people attend that. So people are wanting to come to this, they are keeping up connection with each other. We say at the end of the group, look, you've got on so well with each other, how about you keep on meeting? And we don't have to be there, and they do this. Do you do this?
We do.
Yeah. So I just think that's incredible. We don't have to keep doing this. They do it themselves. The latest thing that we've added to this is, and I guess it's coming from an article put out by the Lancet, which has put together all the things around risk and delaying onset, where we're really getting the idea that in midlife, people need to be making the changes. People need to be looking at the lifestyle factors. If there's an increased genetic risk in some fashion, which they've calculated to be 7% of the relative risk of developing major neurocognitive disorder, then you can actually change the other stuff to delay it. So we're giving them information to pass on to their family and their friends, which is really important, because sometimes the family that are saying, I don't want to know, are saying it because they're scared. They are really scared that this is going to happen to them. So this is a really good thing to be able to say to them, look, we can't promise that you won't develop it, but there are some things that can help, even if it just delays it. So we're passing on that information along with a lot of stuff around people actually helping themselves and managing this whole chronic illness, which, as I say, they may experience for quite a number of years.
Well done. Thank you. Very good. So, yes, Helen, I think not many of us have had formal training in how to do a mocha, but we do them. And I had the delightful experience the other day of going online and finding one in Italian, because I had a lovely Italian lady who really didn't speak much English. So we sat there and did the mocha. So I had the English version, her daughter-in-law had the Italian version, and between us we managed to do a very good mocha. I'm not sure whether it's actually how one should, but it was quite helpful, really. It was quite exciting, so I enjoyed that a lot. And I'd be really interested, there may be questions for you afterwards about some of that around how we should be doing that, because I think that is a fascinating area, because we are using those, I think, predominantly. Do people actually use MOCA in your practice quite a lot? Or MMSE, yeah. Our final speaker, we've given a bit more time to, because she's going to be introducing you to some things that are new, hopefully, to you. Alison Douglas is a barrister who in 2014 got the New Zealand Law Foundation, was the International Research Fellow, and she did some research on updating New Zealand's law and practice around mental capacity. And what she's developed is a toolkit on assessing mental capacity. And I don't know how many times you have been asked to determine whether someone is mentally capable of making a decision or not about something regarding their welfare, their well-being, their place they want to live, or whether they can even make a will. So Alison's toolkit is designed for people who don't do assessments all the time, for those of us who do them from time to time, and I believe that's what she's going to tell us about tonight. So I'll just bring up your PowerPoint, Alison, and you can come and sit. Thank you. And you've got your own little thing. She's more important than the rest of us. Yeah.
Just as instructed. My children say, Mum, I don't know if I've got the capacity to do that right now. Like the dishes or something like that. Is that on? Right. Kia ora tātou. Thank you very much, Susie. Of course, I met Susie coming along to sort of have a look in on the Keezer and the margarine tray, which I thoroughly enjoyed, and I put it as part of my wider research project, really looking around the law and practice, which I've called mental capacity law, which is the name of the legislation in the UK, in England. And I was fortunate enough to get this research fellowship, and I went to England and visited all the players, the Court of Protection, the judges, the academics, the doctors, and people working under that legislation, and came back to New Zealand very excited about how we could update our law. The particular law that we're talking about is the Protection of Personal and Property Rights Act, the Triple PR Act. People, put up your hand if you've heard of the Triple PR Act. Good, great. Well, the thing about it is that it was actually quite a progressive law for its time. It was back in 1988, and it was at a time when we were deinstitutionalising institutions like Kimberley and Levin and other sort of psychiatric hospitals, and allowing for welfare guardianship, essentially, of people with disabilities. But moving the clock forward, we actually haven't updated our law and really looked at it. And of course now, with the avalanche of older people with dementia as but one example of people where they have impaired capacity or competence for decision making, we haven't revisited the law yet. So many aspects of our law around health and disability have advanced, but not the adult guardianship laws. So. And one of the things I was really impressed with in the UK was the code of practice that they have. And despite all of this, they've got a beautifully written law. You can have the most perfect law, but if you can't implement it in practice, then you're going nowhere. So what I took from that is that we needed to make a first step. If at this point in time we haven't got a government that wants to reform the law.
We haven't got a government at all.
We haven't got a government at all. But believe me, I've sent my report. It's essentially a law reform report, and there's kind of a silence around this area. Yet we know, so many people on the ground. I still get contacted weekly across the country by doctors, patients, people, social workers, all the time. So, it does have to come from all of us in terms of wanting to change the law. But anyway, what I took from it is that a first step towards this would be to create an aspect of a code of practice which is giving some transparency around this issue about how we assess mental capacity, okay? because another aspect of our law is that we have ACC, we don't sue doctors actually, and we don't actually see how decisions are made. So we can take complaints to the Health and Disability Commissioner, but in the scheme of things, this area of law has actually come out of traditional medical law, and the idea about how can doctors and others make decisions when people can't consent, and the lawfulness around that. But what they've done, of course, in England is they've moved that forward considerably, and as I say, and in several other countries. So the toolkit is, and I should acknowledge my colleagues here, Greg Young, who's a consultant psychiatrist based in Hawke's Bay, but for Capital and Coast DHB, and John McMillan, who's the Professor of Bioethics here, and I have a sort of an honorary position through the Bioethics Centre. So we kind of got this all together, and we consulted with a number of doctors and others, and developed this toolkit, which you can find online under there. I've got a few hard copies, and you can also find it on the Law Foundation website. Now, we're developing that. We're going to write a book, because in the UK they have a guide for doctors and lawyers, and we're sort of wanting to develop that. But it's particularly a multidisciplinary area, of course, and as we've heard tonight. So that's all work in progress. So your extra funding, now we've just heard, so I'm also working with Auckland University, the Goodfellow unit, and they're developing the toolkit into an e-learning resource for GPs. But the Northern Regional Alliance of DHBs was only prepared to give some money towards that project, because they thought it should only be for Northern GPs, not the Southern ones. Get that, but that's how sort of disjointed some of these sort of funding arrangements are. But the good news is that the Goodfellow unit, as you know, does clinical education sorts of things, and we're going to develop the toolkit online as a learning resource for GPs as well. So, it's sort of filtering through, and we're always after feedback, and we have, in fact, conducted a survey of doctors as well, which we're sort of writing up. Because a lot of, as I understand it, for GPs, often we don't have, you're not often actually necessarily doing this on a regular basis, so it's kind of being thrown something, what am I meant to do? And the bad news is, and I can't sort of tell you that in the next sort of 10 minutes, but what I can do is just take you through a few concepts, and also just basically our 3-stage sort of approach to how we do capacity assessments. So, so I'll sort of get straight on to that. One of the interesting things is working with a psychiatrist and an ethicist, is we all come to this from quite different angles. And that's the beauty of it, because, as a lawyer, I'm really into process, because for me, it's about the transparency of the process, that we can expect 2 capacity assessors to come up with 2 different judgments about a person and their capacity. But as long as we can sort of see how they got to that point, then that's okay. And we know that lots of people, international reviews show that this involved 50 studies, that, up to 45% of patients in psychiatric settings probably lack capacity for decision making. That's what we're talking about here. And in the UK, lots of people with dementia. Of course, as we've heard, dementia doesn't necessarily mean the status of your diagnosis doesn't necessarily equate to you not having capacity for decision making. So that's quite an important point. It affects all sort of spheres of life, and as GPs, it probably starts with someone coming in to say, questioning whether they have capacity to drive, and that's possibly a little bit more physical and mental sort of issues around. But that's a really, really important one, because we're often talking about people's liberty as well as their well-being, and but it starts with, when people say, it's not within my scope of practice, well, every health practitioner assesses a person's capacity to consent to any healthcare procedure. So that's your bottom line. And I actually went to the Medical Council to check that one out, and they said, well, actually, yes, it's within every doctor's scope of practice. It's just that perhaps, hasn't had the attention. And I suppose gone are the days where you walk across the hospital to find the psychogeriatrician, to, if you're the surgeon, and you've got an elderly person, fractured hip and, can't consent, whatever. Of course there'll be, referrals, but there is a need, at the ground level for education around that. Property issues, of course, testamentary capacity or capacity to make a will is a really biggie. And lawyers, get quite involved in those cases. What you see in the court's decisions is that lots of decisions around property and finance, because we argue about property and finance in court. We don't hear about the person who refused medical treatment or the, the care and welfare issues so much. But that's not to say it's not out there. And the issue of enduring powers of attorney, that is when you make a deed to appoint someone else for when you lack capacity to make decisions for you, is very, very current and very topical. So, in the UK, there's cases about capacity to have sex because local authorities are responsible for housing people with learning disabilities. And, if someone, takes up a relationship with someone who's just a paedophile who's just been discharged from, jail, prison, these issues, they have actually a real duty of care issues around people. So there's quite a wide range there. So why it is important is that it's really about whether a person's decisions or actions are valid in law, because if they're not, then someone else will make a decision for them, a substitute decision maker. And another important point about this is that it is a legal decision. So if you're asked to do a capacity assessment or report, you for the court, for example, then you're feeding into a legal decision. So your report isn't the whole answer, it's a piece of the equation, it's evidence towards it. So there are several, many cases in the Court of Protection in England where there have been, psychiatrists or whoever, even and social workers do capacity assessments in the UK, where the judge has said, I've listened to that report and listened to that report, but actually I find, so it is a legal decision. And when it's at the level of you giving consent to someone in healthcare, well, that you're making that legal decision. But if you're feeding into, legal proceedings, then you're part of the evidence. So one aspect for GPs is that they bring a lot of information to the table because often they know families, and there's all that sort of collateral information that is relevant, as well as the clinical information. So the two key concepts in mental capacity law, sort of 101 in a few minutes, is the issue of capacity itself. So I call it the bright legal line in law. So if you have capacity, and we have a very individualistic approach to this in law, then you can make unwise decisions and you can be eccentric, you can do what you like. But if you're over the other side of the line, then other people will, make decisions for you, or the court will intervene, or someone else will be appointed to make decisions. So the importance of a capacity assessment is which way you go over that line. And of course, as we know, not all cases are clear-cut, and there's lots of borderline situations, and that's why the reasoning or how you make a decision about whether someone has capacity or not, in your opinion, is all important. And that's also the ethics of it too, because it's not, clear-cut. So we have to sort of recognise that we put our own value judgments into these, how we come to that. And the other important concept is best interest, so that when decisions are made by others, then they are required to make those decisions in the person's best interests. And the English sort of medical law, which we have drawn on, and still do, started with the idea it's really about what a good a body of medical opinion would believe would be is the person's best interest. So it was very kind of paternalistic as to how we viewed that. Now, the English law has even codified how you assess best interest, and it takes into account the person's wishes and feelings, or in human rights terms they talk about the will and preference of the person. So they expect those factors to feed into, even if it's a decision made by someone else. So, and And one of the sort of the traps, I suppose, in this whole area is when we sort of conflate the two. And it might seem a little bit compartmentalised, but this is the way the law works. So there are several cases in the UK, and this is one, CC and KK, where, and this is often about living arrangements, and it would be of interest, for needs assessors too, because the judge in this case, this was someone who wanted to remain in their own home, all the classic sort of medical conditions that were really sort of pointed to say that they should have care in their own home. But the judge found that this woman could make the decision and was critical of her not being provided with the relevant information. And this is what needs assessors do. They provide the real options. You don't have to provide everything that you want, but you have to say what is available. And it's that information sharing thing. So, and the judge was saying that it's so easy for professionals, including judges, because you want to do things what you think is in the person's best interest, not necessarily standing back and saying, well, actually that person can make that decision for themselves. So, and we have many equivalent kinds of decisions in the family court, and a lot of the family court decisions are in and around the sort of living arrangements issues about when people are discharged from hospital, whether they should be can return to their own home or should be in residential care. And just to flash by you, this is a human rights issue now, and the Convention on the Rights of Persons with Disabilities, and we all have disabilities essentially, but people with dementia do too, has really focused internationally how countries look at their domestic laws, and there's a really important principle about supported decision making. So it's not just important about how you assess whether the person has capacity, but how you can support them as much as possible at the beginning of the process to make decisions for themselves. We ratified that convention in 2008, and there hasn't really been too much talk about it since. But we've put it into the toolkit, and we're trying to also bring in what I call the cultural dimension into capacity assessments, because I think it's very important that New Zealand puts its own cultural blush on all of this. We have experience about doing things Māori, but also the diversity of cultures, and that we expect doctors to be culturally competent. And so if you're assessing someone that's from a different culture than your own, then we recognise, knowing how to recognise those differences and how to engage with people. The Māori term is whakawhanangatanga, that idea of engaging with the person to make those connections so they feel more comfortable. So I'm going to quickly, so you're going to wave at me a few minutes before you want me to stop. So there's lots to talk about, generally, but let's sort of talk about the capacity assessment. In the toolkit, we've put a checklist, and then we've built it into sort of 3 stages, the sort of before, during, and after. Okay. So the first real question is, why are you being asked, in fact, to assess this person's capacity? Because, in the consent situation, if we've got lots of compliant, incapacitated people in hospitals, and no one sort of questions them unless they turn around and say no, right? Mm-hmm. So, asking what that sort of trigger is a really, really important sort of component in it. So, and as if you're the GP, why is it that daughter that's asking me? Really worried about, and of course GPs often get caught in the middle with family dynamics. But can I just say that you're used to that? I mean, you are professionals and you do get caught up in family dynamics. So it is, I'm not saying it's easy. We lawyers do too, by the way. But so the question is, what are the triggers? And also in law, we talk about capacity being decision and time specific. Okay, so there could be a whole series of decisions, And of course, someone who has capacity to decide what to have for breakfast or even to get to the doctor doesn't necessarily have capacity to decide on an elective surgery operation or make more serious decisions about whether they need support in their home. Okay, so it's all very nice for the law to say you sort of break it down into decision specific, but the real message is it's not a global assessment, and it's a time one as well, because as we know, people have fluctuating conditions, and delirium is one, of course, and this does complicate things. So we know that, for example, turning up at the rest home, at sundowning is not a good time to optimise a person's capacity assessment. So, I mean, my introduction to this, as I should say, is that also I've spent many years representing people who, for the court, when we make an application, the court automatically appoints a lawyer. And so I often been in the situation of interviewing GPs and doctors and asking them, how did they reach the decision that this person lacks capacity? Because if they do, then the court will then intervene and look at the various options. So, so when we're starting off, one of the other aspects of this is whether there's any reversible medical conditions. So, delirium is sort of a case in point. And those are clinical issues that you know all about. But they are questions that you need to have at the forefront of your mind. And really that idea of exhausting whether all sort of efforts have been made to support the person in the first place. So these don't always fit into the 15-minute time slots of a doctor, but here we go. So the first part is really a gathering of information in terms of preparing for the assessment, thinking about what the trigger is and what is the decision, because obviously the seriousness and the riskiness of the decision is all important, and there are sort of principles around sort of proportionality essentially, is that if the consequences that someone's going to die or could die, then that obviously deserves quite a bit of attention, whereas if it's a relatively minor consequence or risk, then that's not necessarily the case. The other aspect is that we have in law different thresholds for or legal tests for capacity or incapacity. And if you're confused, we also use competence. Now, I know some people use that in a clinical context. I'm just debating with a psychogeriatrician actually in Wellington at the moment about how he uses competence. But what we've done in the toolkit, and says, forget that, in law we use capacity and competence interchangeably, and I think for the purpose of this exercise we should too. So it's okay to use both terms. So, for example, capacity to consent to treatment is in and around understanding the nature and effects of the proposed treatment, weighing up the risks and benefits and the consequences of not having the treatment or having it. So if we're going to appoint a welfare guardian in the family court, we have this bizarre sort of test that the person must wholly lack capacity to understand the decision and foresee the consequences of that decision, which doesn't really reflect the real world we live in unless you're an unconscious patient on nutrition support. That's the basis that we appoint welfare guardians. If we rushing off to get the Needs Assessor to do an assessment about placing a person a one-off placement, and we're getting a one-off personal order in the family court, the threshold is that the person partly lacks capacity. Now, when I gave seminars in the UK, they laughed at me at that. So, and maybe my words came out garbled, thinking probably she partly lacks capacity, but it's kind of what does that really mean? I mean, partly lack capacity, Maybe it means that we have capacity in some domains but not in others. But the way it's interpreted is it's actually, by our court, is a relatively low threshold to say if partly lack capacity to deal with your finances or partly. So that is problematic. But if you're the assessor, you need to know what that is. So, and if a lawyer's briefing you or someone asking you, that's a fair question to ask. What's the legal test I'm working with here? Okay? And of course, all the sort of other things that are built into any sort of interview assessment process that you might do. Where and when is important. And also, you know, obvious supports like, you know, hearing aids and glasses and, you know, I mean, these all seem practical things. So I'm just going to sort of flick through this to the second stage. So really, there are lots of international guidances around capacity assessment. In the US, the MCAT, the MacArthur assessment tool is quite a sort of a gold standard. Is one, but they're usually all based, Ganzani, the Australian author, they're usually all based around a semi-structured interview. And the point about it is really assessing the 4 abilities or the 4 parts to any sort of legal test, which is we've based it on the English test, which is in effect the same as our test in New Zealand law, which is whether the person understands the nature and purpose of the particular decision. So it's an understanding, a reasoning around that, whether they can retain the information at least for the time needed to come to a decision. So you don't have to have, you know, magical memory, but you need to be able to hold that information for long enough to manipulate it. And then thirdly, and probably the trickiest one can be whether the person can use or weigh the relevant information. So we also talk about under the PPPR Act whether the person can foresee the consequences, which is quite a hard one because we don't, you know, sometimes we can sort of foresee the consequences of our decisions. But anyway, so that's often the trickier one about that idea of appreciating and being able to manipulate that information in a consistent way for that person, sort of taking into account eccentric beliefs, you know, religious beliefs, cultural beliefs, you know, those, so that it does bring in those sort of values, and whether they can consider other options or reject them. And then a standalone also ground is, or ability, is this, whether the person can communicate. So dealing with someone with stroke is a very good example here. Of course, you know, if they can use the fingerboard or nod or something, then that's fine. But of course, stroke in itself throws up issues around with, you know, depression and other things that can be going on. So that's sort of the basic core test that is applied to any particular decision, and it's a reasoning task. And I think I should probably, you'll see our discussion in there. So then the third part, and so this might mean more than one interview, and it might mean more time depending on what information you have available to you, and if there's also some, you know, inconsistencies. So the third part is really deciding whether you do in fact have enough information to put it together in some form of report or certificate or whatever form that might be. So we've broken down capacity assessments into what we call informal assessments. So if you're just getting consent from a patient, you might just simply be writing it up in their notes, right? But if you are being asked to write a report, then there'll be some more sort of formal format to that. And of course, you know, there are real, you know, principles of honesty and disclosing, of course, to the patient that that's in fact what you're doing and what the outcome of your assessment is, and where you get to on that. So there's lots here. Just a little bit, yeah?
2 minutes.
All right. Just a little bit about the PPPR Act, because moving on from, you know, understanding capacity to consent to healthcare, the PPPR Act is something that you do need to have some, what I call legal literacy about, So the point about the toolkit is that it's both a clinical and legal guide. So just as if you are committing someone under the Mental Health Act, as doctors you need to know some of the basics of the law and apply, your clinical assessment for that purpose, or indeed, an ACC certificate. You need to, and so the thing about the PPPR Act is that understanding some of the principles around it. So an enduring power of attorney is often when people get asked to activate them. So you make an enduring power of attorney for when you have capacity for that time when you don't have capacity. And a GP will be asked to, there used to be a certificate, for some strange reason they decided to remove the forms, produce a report, because what you're essentially, or a certificate, what you're essentially doing is overriding the presumption of competence. So the starting point in law is that everyone is presumed to have capacity unless presumed otherwise, okay? And really what your medical opinion is making the case to overturn that presumption. So that's why we looked, when in the hard cases, we're actually sort of looking as to what, on what basis you've reached that opinion. And it might be, so the more information you can put there, in there, the more useful that is. So I say to doctors that the actual form for the welfare guardian does sort of have boxes, but I sort of say it's not a tick the box sort of exercise. So when I'm the court appointed lawyer and I sort of come to you, so on what basis did you say that this person totally lacks capacity? It's about saying, well, in my assessment, there were aspects of, those four abilities that, take you over that line, over that presumption of competence. So, and one final point, which is, red flags and undue influence. So do people understand that the legal concept of undue influence is we have influence is good and bad, but where, people are in a controlled situation or coercive and they're not acting voluntarily, then they can be unduly influenced. So, working with families and in the community, you'll be seeing this all the time. And the question is, does it reach, we do get into situations here of, abuse and misuse of some of these legal authorities that people have in and around, their relatives. So, and I would argue that our law, for example, why don't we have a register for enduring powers of attorney? It seems so obvious to me. So that, in George Street, we had a client, someone who just walked in and withdrew their mother's money savings. This happened just around the corner from here. And there are, sadly, those other areas. So just on that point, age concern, of course, is another useful agency too. And social workers can give quite independent sort of views on things, and that's actually some of your eyes and ears as well. So I think those, having as much sort of collateral or sort of independent way of checking. So you might have the family member in with your patient, but you might spend periods of time when they're not with you as well, or you might be sort of checking other sources. So because it's as much as possible you're trying to give an independent and objective assessment. And MOCA, that was MOCA and MMSC, they're tests for cognitive impairment, right? So they're screening tools. They aren't a capacity assessment, right? And so because we use this functional test, that's really got to be the focus. It's not to say that that wouldn't feed into it, but of course that doesn't deal with frontal lobe issues. So I think that's generally accepted in the literature now. That and another aspect I've found is that psychologists, of course, also come to this slightly different sort of way that they would perform an assessment as well. But But that's all fine. The point about it is, and we should really be having nurses doing capacity assessments as well. And so that really goes to the sort of the clinical sort of education and training across the workforce, I think. So I'll finish there, is that right?
Yeah, thank you.
Yeah.
So I think, Alison, probably the thing that, having read Alison's extensive document,
You haven't
and
read
took
that,
it,
surely.
I have. You asked me
What,
to
300
proofread it.
pages?
Yes, I did.
Right.
The things that I took out of it that have been really useful in my practice is that a capacity decision is specific to that occasion and is not global, and that really helped me understand when I was helping patients make that decision. And I guess the kind of quick and dirty one we do is always the driving assessment, because nobody's checking up on us. We sign people off to drive their cars, quite frighteningly at times, because it maintains their independence, and it's a very difficult decision which we make in very short spaces of time. I don't know whether you've got any comment on that. It's a little bit like my Italian mocha, probably not great, but it happens. But then, other things come along, like a patient, a couple of patients who came to see me recently, a couple who both have cognitive impairment, significant, severe cognitive impairment, living in their own home. And their daughter brought them along and said, you just need to sign these forms here so that they can change their welfare guardian from my brother to me. And having read Alison's documents was quite helpful, because I remembered this idea about that. Well, there were a number of things, but one of them was, this person needs to demonstrate to me that they understand what we are signing away here. And so I said to them, do you understand what we're doing here? And I said to the husband, what is it that this form represents? And he was completely unable to tell me what it was. And I said to the wife, what is it that this form represents? And she gave me a kind of an answer, in a way, because we'd just been talking about it. So we kind of went on in the conversation a little bit, and I came back to her and I said, tell me again what it is that this form represents. And she was completely unable to tell me what it was. So the capacity to hold that information over time and demonstrate that they understood it was clearly not met, which meant I didn't really have to go much further, because I could turn to them and say, this is not a form that can be signed for you people at this time in this situation. This is not appropriate, But those are the sorts of determinations we get asked to make. So
that's a good example. Yeah.
In our few remaining minutes, do you have questions for any of our panel members? Susan, do come back.
Sorry, I'll go back to this.
So
shall I turn this off?
That you'd like to ask?
Shall I turn this?
Realistically, an assessment like that is going to take how long?
Right. Well, Greg talks about this. So he says his starting point is 30 minutes. Okay. And so his point also is that sometimes it's necessary to see the person twice, and that the place and time is important. So obviously seeing, just as the psychogeriatric or health for elder people would go into the home, and the nurse might be sneaking round the back, sort of talking to a relative, or what I mean, it's sort of getting an impressions, that there might be more than one person feeding into the assessment. So I mean, obviously if you were going into a person's home and seeing them in their own environment, which may well be more supportive, then that's going to take longer also, isn't it? But I mean, I don't know exactly how the referral sort of system works. I sometimes see it's faster and slower in different places, but presumably you have access to consultant psychiatrists and geriatricians at times.
Not for the day-to-day stuff.
No.
It would be rare that you would ask him to make a day. You might do competency to do an EPOA, you may do a competency to be an adoptive parent. I mean, there may be a dozen different things.
So if you're asked by a lawyer, for example, that's largely about how organised the lawyer is, and so there's quite a bit going on in the legal community, the CLEs, not the CMEs. So I'm just speaking at the Family Law Conference next week, and about what lawyers need to know and how they should brief doctors. So if they're going to send you a form, it helps that they've sent you everything that the first part, the preparing for the assessment, who the relevant players are, what are the documents, the information you might need, and all that so if you're going to talk about whether they should have a property manager, roughly what their financial things are, so all that groundwork, an organised lawyer can get that to you. But if you're starting from scratch, then you're going to have to do more preparatory things. So, and it really depends, on how. But the thing is, doctors should really push back, at the lawyers, because I'm finding so many lawyers. I mean, the other thing is lawyers need to actually start understanding that they, in fact, assess their client's capacity as well. They might, if appropriately, they should refer to a doctor for a medical opinion when they need to. But there'll be many instances when they, in the professional client relationship, are essentially, assessing capacity. So, I mean, that's one factor. Your referrer needs to be. You need to get them working for you, basically, in terms of. Your time.
Yeah.
Sorry.
It's just one over here. Yeah.
Yeah. Can I ask, Alison? So you mentioned in one of your slides that regarding EPOA, things changed in March 2017, presumably from the old Section 4 and 5 and the EPOA forms.
Oh, there we go. Very impressive.
And what's changed exactly?
Yeah. Well. So actually it goes back to, in 2001, Age Concern led our Law Commission to actually do a law reform report about how we should amend the PPPR Act around misuse and abuse of enduring powers of attorney. So in 2008 they put in extra rules around witnessing that you had to, if it was a husband and wife, they had to have separate witnesses, and then these forms, more forms to fill out. But actually there was they were counterproductive, those reforms, because it made it more expensive for people to go and make enduring powers of attorney, and sending someone off to another lawyer doesn't actually stop misuse and abuse. And as it happens, they had those forms of medical certificates. So the government actually reviewed the forms. They refused to enter into any discussion about a register or any wider aspects of the law, and they, for some reason, and they had a geriatrician on their working group, but they decided that they didn't need those forms. So now there's just a set of prescribed information. So I mean, you could work that out for yourself, but there isn't a template as such. But
a template to invoke the power of attorney, or a template for what?
Oh, so no, there are definitely templates for. So in theory, anyone can go, a member of the public can go online to the Ministry of Justice and find the enduring power of attorney forms. But to activate so to get the health certificate to say that this person now lacks capacity and therefore should have the Attorney Act, that the report that you do is no longer in a prescribed form. But it's just, why they did that is, beyond. So another aspect of all of this is that there is no public body that actually champions the law in New Zealand. So if you're in New South Wales, you've got the public, the Office of the Public Advocate. In the UK, they've got the Office of the Public Guardian. And and everyone working in here would be aware that for example, we don't have enough welfare guardians. There are plenty of people that don't have a family member, or there's too much conflict in the family. And that is a real issue. Otago, of course, has got the Otago Welfare Guardian Trust. Are you aware of that? So there's there are a lot of problems. So, and essentially making an enduring power of attorney, you have to go to a lawyer and pay privately to do that, and there's lots of people that can't do that. So
I am going to stop us there because although there's a lot of things we'd like to know more about, hopefully, although we have got to a fairly difficult point, we're starting from the point of diagnosis where we actually are going to try and achieve some more positive outcomes, because we know where we're going to send people, what we're going to do for them, and why it's useful. Okay, and if they get to the point where they can't have capacity, Alison's document is not 300 pages long, only the bit that I read, but the actual toolkit is really, really accessible, so do use it. It's really helpful. So I'd like to thank our panellists for coming on tonight.